Dear ladies and gentlemen, on behalf of the DESCaRTES working group of the ERA-EDTA, welcome to this ERA-EDTA e-seminar, which is about living donor kidney transplantation, how to improve the living donor pool. I have one introductory remark. By participating live in this session, participants will earn 1 European credit for their continuous medical education, and this is a benefit for ERA-EDTA members. I would also like to stress that this session will also be available as a webcast later on. I'm happy to introduce the faculty of this afternoon. My name is Luuk Hilbrands. I'm a nephrologist working in Radboud University Medical Center in Nijmegen, the Netherlands, and I will moderate this session. Then we have as speakers Geir Mjoen. He's a nephrologist in Oslo University Hospital in Norway. And as a second speaker, we have Emma Massey. She is a psychologist working in the Erasmus Medical Center in Rotterdam in the Netherlands. Then we have as panelists Marta Crespo. She's a nephrologist working in Hospital Del Mar in Barcelona, Spain. And we have Christophe Mariat. He's a nephrologist working in University North Hospital in Saint-Étienne in France. So I hope you have a very interesting session, e-seminar, and we will start with the presentation of Geir Mjoen. Geir, please unmute yourself and start your presentation, if you can share the screen.
Okay, now I'm unmuted and I'm just going to share my presentation. Okay, these are my disclosures. This is the subject of my presentation, which is optimal information of living donor kidney candidates. What goes well? What can be improved?
Geir, we do not see your presentation.
Oh, okay. Share screen. How about now?
Yeah, it's fine.
Do you see it now?
Yeah, it's fine.
Yes.
Okay, great. These are my disclosures. The title is Optimal Information of Living Kidney Donor Candidates. What goes well and what can be improved? And it was lucky that I got this assignment because as a member of the DESCaRTES working group, we have just performed a survey of European transplant professionals. And the title of the survey was Long-Term Risks After Kidney Donations. How do we inform potential donors? And the survey was a collaboration between the DESCaRTES and the EKITA transplantation working groups. Questions were designed to capture how donors are informed concerning long-term risks before entering the workup process. We tried to find out which risks were described and how do responders interpret the magnitude of risks. This slide is just a summary of the known long-term risks from the current literature. We decided to focus on hypertension, end-stage renal disease, pre-eclampsia, and mortality. We had respondents from all over Europe, there were 392 respondents. Most of them were nephrologists, and the mean experience was 13 years of working with evaluating living kidney donors. Most of the respondents were from the central part of Europe, the countries that are in green. So I now want to show you just some of the responses we got. And then I will try to interpret the responses later. So one of the first questions we asked was, do you discuss hypertension, the risk of developing hypertension after kidney donation? And a majority of the respondents said that they always did this. And almost no one said that they rarely or never discussed the risk of hypertension after kidney donation. This is a well-known risk, and there is little debate. It is not very controversial that this is associated with kidney donation. Then we asked, what about written information? Do you discuss this in written information? And a large majority said that they did. Then was the risk of end-stage renal disease. This is a very rare occurrence in the general population, and it is also a very rare occurrence among living kidney donors. But of course, for those who experience this after living kidney donation, this is a very, very hard and a disaster for those who are involved. The publication best describing this are two publications, one from our center in Norway, from Kidney International in 2014, and one from the Journal of American Medical Association in 2014, which is the figure that is shown on the screen, with a increased relative risk of end-stage renal disease for live donors after quite some time of observation. So we asked the respondents in our survey, do you discuss the risk of end-stage renal disease? And almost everyone did. Furthermore, we asked, do you discuss this in writing? And a majority of respondents said that they also discussed this in writing. For younger female donors, there is the potential risk of increased risk for preeclampsia after kidney donation. And this is a paper from 2015 with the primary outcome of a combined outcome of gestational hypertension or preeclampsia, where the proportion of donors' pregnancies with this complication was 11%, while in the control group it was 5%. So this was an increased risk. And we asked, how often do you discuss preeclampsia with potential donors? And it was less than for the other two potential complications that I just showed you. And the same was when we asked, how often do you discuss this in writing? More than half said that they did not discuss this in writing. Then we asked, do you test? Do you test whether the donor has understood the information about long-term risks? And most of the respondents answered that they always or often test whether the donor has understood. Then we asked, how do you test? And most of the respondents said that they would ask if they understood. A third said they would pose specific questions. And very few said they would have a written test. And also very few said that they did not test at all. So this is a summary of the responses. And we see that for the risk of hypertension, a lot of respondents said that they would always discuss this. And this is much different from the risk of preeclampsia, which is discussed less frequently. And the pattern was the same for the written information. So for this, we concluded that there are large variations in which long-term risks are disclosed to donors. And it seems that hypertension is the least controversial risk, while for preeclampsia, it was different. So what about rare outcomes? If you are a kidney donor, your relative risk for later end-stage renal disease increases by 10 times in one study. So on the other hand, since diseases affecting the kidney are quite rare, the absolute risk for your remaining lifetime would be low, at least in individuals from low prevalence populations and at least in individuals who are middle-aged or older at the time of donation. So one could say that you have a high relative risk increase, but maybe it would be like you have 10 times the chance of winning in a lottery. So you have a 10 times higher risk, but if you have 10 lottery tickets, then you are not necessarily thinking that you would actually win the lottery, because the absolute chance for winning a lottery is very small. So this is a comparable way of looking at it. So what we perceive as a high relative risk could, in a low risk donor, could translate into a very low absolute risk. And we asked about this. We asked respondents to estimate the relative and absolute risk of end-stage renal disease during the remaining lifetime for a 50-year-old white male kidney donor. And we gave them 3 different options to choose between: 1.5 times or 3.5 times or 5 to 10-fold the risk compared to not having donated a kidney. And in this slide, from the literature, 3 to 5-fold or 5 to 10-fold is likely to be the correct answers. And then we asked, what is your estimate of absolute risk for end-stage renal disease in a 50-year-old white male donor? And there were 4 options, and ranging from 0.1% through 1 and 2% up to 10%. The correct answer here would be 1%. And the example, the 50-year-old white male donor, is such a low-risk candidate where you would see this combination of a high relative risk and a low absolute risk. So 80% of respondents answered an incorrect combination of relative and absolute risks. However, this is a distinction that can be quite difficult to grasp, and earlier literature has not focused that much on this. So we would expect that there would be some variations in the answers. So for the conclusion, going back to the title of this talk, what goes well? The majority of respondents state that they discuss long-term risks with potential donor candidates, always or often, for all of those risks that we had in the survey. And many answered the survey indicating interest in this subject. What can be improved? Well, we think that the use of written information and checklists should be encouraged. And it is likely that there is a need for guidelines taking into account recent literature on long-term risks. Available guidelines have not taken into account some of the literature that has been published for the last years, and on the other side, we might need some time and some gaining some more experience so that we would know how to interpret these research results and how to translate this into practice, because it is not necessarily easy and there may be many different ways to interpret this. Thank you.
Thank you very much, Geir, for this clear presentation about informing potential living donors and especially about the contents of the information that we give. There will be opportunity to discuss your presentation later on. I would like to propose to proceed first with the presentation of Emma that will focus more on the way we give our information, and a special possibility to do this is by home-based education. And Emma will provide us with the latest insights on home-based education for potential living donors. So Emma, please.
Thank you very much for the invitation to discuss this topic. Can you see my slides?
Yes.
Yeah, okay. So home-based education programs, the question that was posed to me to address today in this seminar is, are they helpful in increasing living donor pool? So I'm going to try and give you some evidence and an answer to this question. These are my disclosures. So I'd just like to start with what are the barriers to living donor kidney transplantation? And I do the psychological screening in Rotterdam of our living donors, and I just wanted to start with potential barriers and some examples of questions that one lady asked to me. She wanted to donate to her partner. She came in and these were a number of questions. For example, if my kidney fails, will I be put on the top of the waiting list? Are my children at risk of kidney disease because my partner has it? Will donation influence the chance of female relatives having children? Oh, sorry. If the kidney fails, can I get it back? And can you help me with home help whilst I'm recovering? So this just indicates the very various questions that a potential donor may have, and that these could become, in the mind of the donor, barriers to donation. So what do we know about other barriers to donation, to living donor transplantation from the perspective of the patient? Well, evidence has shown us that patients that are older, have a lower socioeconomic status, have a lower level of education, those who are perhaps more isolated with no partner, and particularly those from ethnic minority backgrounds are much less likely to have a living donor transplantation. Unfortunately, these things are less modifiable. So what about modifiable factors, things that we could address? Well, we know also from research that particularly in the early phases of kidney disease, patients often struggle with acceptance of the illness, psychologically accepting it. This can also be associated with low knowledge about the living donation process. A lack of the appropriate knowledge can lead to concerns and misunderstandings about the outcomes for donors. Discussing living donation can be embarrassing, awkward, and most of the time patients don't want to put pressure on family members, which is completely understandable. And for some people, the role of religion is a potential barrier, not knowing the role of religion in particular. There's often a lack of awareness and a lack of knowledge among family members about living donation, and in some cases, some evidence has shown that there can be negative social influences on other family members regarding living donation. And this really can culminate in poor communication about this topic from both sides, from the patient side and from that of the family. But these are things that we can address in a good educational program. So James Rodrigue in Boston in the USA, he developed this home-based or house calls approach to educating patients and their families on renal replacement therapy. And we agreed with this approach. And what do we need to achieve living donation and transplantation? We agreed that a timely education on all options at the moment that they're available to the patient is needed. We need to standardize information, which is what Dr. Mjoen was talking about, so that there's equal access to all individuals for living donation, and that it's not dependent on the professional and their opinion or their own knowledge level. And what you need is an outreaching approach, because at the end of the day, any donor will come from the social network. So if you can bundle these in an approach, this should lead to a well-informed patient and a well-informed social network, which should lead to timely and well-informed decision-making surrounding renal replacement therapy. So we took Jim Rodrigue's idea and we translated his approach to our setting in the Netherlands, and this is what I want to, the findings that I want to share with you today. So home-based education in the Netherlands looks like this. It commences with an initial intake session where we graphically plot the social network in a sociogram. We prepare the group session and we support patients in inviting anybody who they'd like to invite to the group educational session. It doesn't have to be just family, it can be broader than that. Then we arrange a group educational session, often in the weekends or in the evenings. This is offered to patients and any member of their social network that they want to tell about their situation. Often we use 2 educators at the same time because it's a group process. And we give information, so it's information sending, but also a large part of the protocol is generating a discussion on the information, so it's not just static. And an important point is that we use professional translators and we never rely on family members for this translation process. And finally, there's a follow-up moment to assess any further needs. So I'd like to share with you, first of all, an impression. This is what it can often look like. Here you can see top left is somebody had rented a football canteen, and on the right you can see here this is a living room packed with rented chairs and a beamer and very professional. So I'd like to share with you the findings from our original 2 randomized controlled trials. These were conducted in the Rotterdam region of the Netherlands. And this is a very high level presentation of the findings. You can find the details in the papers. So on the side of the patient, we found an increase in knowledge about all renal replacement therapies. Fears and concerns regarding living donation decreased and communication increased. We also asked people that had attended these group sessions from the social network to complete pre and post questionnaires. And here we saw again an increase in knowledge on kidney disease and therapy options, a decrease in fear and concerns regarding living donation, and an increase in attitude and willingness to donate. And this resulted in one of the randomized control trials in which we also had a control group, so we were able to compare in an increase living donor kidney transplant activity, and that was combined inquiries, evaluations and actual donations. And just looking at the actual donations, you can see here there was a 10% level in the control group versus 43% in the experimental group that had received the home-based education. So hold that 43% in your mind. So these were studies done in a controlled setting and only in one region in the Netherlands. but these were quite good results. So we wanted to take this a little bit further and see, could we replicate our findings in other regions of the Netherlands with slightly different demographics? And could we find generalizability for the usefulness of this approach? So I'd like to share with you our national implementation. This took place between 2016 and 2020. So we were able to invite over 1,300 patients to participate. This resulted in over 1,000 intake sessions. This is the initial session at home with just the patient, sometimes with the partner. And this translated into over 600 home-based educational sessions over the space of these 4 years. And where we were able to replicate our findings, yes. So we had, what I should have said on the previous slide was, we conducted the national implementation in 8 hospitals in the Netherlands, so 4 academic centres, which is where the transplants are carried out, and 4 large referring regional hospitals with large dialysis units. So here you can see the findings for knowledge. We were able to replicate our earlier findings in both the academic hospitals and the regional hospitals, with a significant increase in knowledge after the educational sessions, both amongst the patients and the social network. And in the communication, on repeating the communication, we found in the academic hospitals we were able to replicate this effect, and in the regional hospitals we weren't. And interesting to see here is that in the regional hospitals, communication was a little bit higher and it did increase, but not significantly than in the academic hospitals. So it's partial replication of the increase in communication. What about living donor transplant activity in this group? It was an implementation project, so we didn't have a control group. But here you can see combined the inquiries, workup and actual transplantations with a living donor was almost 40%, which is comparable to the experimental group in the earlier randomized trials. So this, I think, shows generalizability. So to conclude about this implementation project, the findings were replicable, and we could show generalizability of this approach outside the original controlled approach of the controlled setting, and in particular looking at the living donor transplant activity. Findings that I didn't present here, but that I'd like to share with you is that we also asked the patients whether they were happy with this approach and whether they appreciated it. And we found a very high appreciation amongst both patients and the social networks for this kind of approach. What we've also been investigating is the costs versus the benefits in quality of life years, and we can conclude that it does require investment. The costs are mainly in staffing of the educators, but we were able to conclude that it's very cost effective, particularly if you see this increase in living donor activity. So what were the next steps? Well, I'm happy to say that during the project, we've been working with the healthcare insurers, and since the beginning of this year, we've been able to secure structural financing for this kind of home-based approach in the Netherlands. So in theory, any hospital can offer this and have this financed by the health insurers. So this has been a large success. So I can imagine that some of the audience might be wondering, well, what about just the same education, but giving it in the hospital? Well, there has been some very successful hospital-based programs, and they have also shown effects on knowledge. But I think what this home-based approach really adds is this improved communication. So there's less evidence for improved communication in the more home-based, in the more hospital-based programs. And Jim Rodrigue, he also offered the exact same content of his program in the hospital versus home-based. So he tested this question and he found greater effects in the home-based educational program, even though the content was exactly the same. So I think this does show you the added advantage of going to the patient's home, taking away those barriers and tailoring the information to that particular setting. And I'd like to share with you the findings of some other authors. They've done a systematic review on this topic. looking at educational programs to improve access to living donation. And these authors concluded, and I very much agree with them, that any good educational package should target multiple learners, so not just patient in isolation, but also those around them. That we need to communicate complex information about risks and benefits, which I think the previous presenter showed very eloquently. And it should be, I think, a home-based approach should be part of an integral package, and we need to think about various modes of delivery that are complementary to each other. Centre-based, of course, also is an important part. Home-based if you can, and perhaps remote technologies or social media could be a complementary mode of delivery. So my answer to this question is yes, I think home-based programs can be very useful in increasing the living donor pool, although not the entire answer, of course. I think it's part of the solution. So have anybody else been initiating these programs? There is some small-scale initiatives, mainly in the UK, in Scotland, and in England, to take this approach and implement it in other settings. So really happy to see that happening. And it's of course an open invitation. If anybody wants to collaborate with us and adapt it to their own settings, then we'd be very happy to think with you on that. So that's just wrapping up my presentation. I'd like to say thank you to the hospitals that participated in this large collaboration, and thank you to those who supported us financially. And if there are any questions, I'd be happy to answer them.
Thank you very much, Emma, for this very interesting presentation and for sharing your experiences. We are very happy that we have two experts also in the faculty in our panel that will give some comments on the presentations that we just heard. And I would also like to invite the audience, the attendees, for posing questions in the Q&A section of this Zoom meeting. If questions from the attendees will arise in the Q&A section, I will try to handle these to the panelists. But maybe Christophe, can I invite you to give some comments on the presentation of Geir on informing potential living donors?
Yeah, thank you, Luuk. If I may, I would start by commenting Emma's presentation that I found very particularly interesting. And first of all, I would like to congratulate Emma for this very successful initiative. Well, in my own practice, I often observe that probably one of the main obstacles for a patient to accept the idea of living donation is regarding the difficulty to generally accept a donation. Have you observed the same thing in the Netherlands? And do you think that it's really a key obstacle we should face and deal with?
Yeah, I think acceptance of living donation is one of the psychological barriers, and to a certain extent, knowledge can improve that. It doesn't always take it away, and it should always be voluntary. Yeah? So also on the patient side to accept it, and you often see conditions to living donation. So, for example, not wanting to receive a kidney from an adult child, and if that's, I think we also have to respect the autonomy of the patient in that. But as long as it's based on knowledge of the facts and the risks and the benefits, then that's okay. So yeah, I recognize this as a barrier.
And I have also an awkward question. Do you, to what extent do you think it would be worth it to have the same kind of initiative, but this time directed to the medical team or the surgical team, since we are observing a quite variable adhesion to a living donor program across the different hospitals? That's true in France, and I guess it has to be true in many other European countries. So do you think that a similar initiative could be worth it?
I think it's a really good point, because in the implementation project that we just carried out, a really integral part of it was training the educators, so getting everybody on the same page, more or less, to agree on the protocol. What are we telling people? Which risks are we communicating? And that we're all communicating the same risks. So this links back to what Dr. Mjoen was presenting, that there's quite a lot of variation. So this can really help if there's structural training and everybody's at least nationally getting on the same page. And this is better for the patient, because you don't have conflicting information. So yeah, this is definitely an area of potential improvement. Yeah, I agree.
Emma, for the sake of clarity, we are now focusing on living donors and giving information, maybe to increase the living donor pool. But is that the primary objective of the home-based education, the recruitment of living donors, or is it a broader goal that we have?
It's a good point to point out. Yes. So of course, this seminar is about improving the donor pool, so that's why the way I've presented it. But our education is broader than that, and it's which links back to what I just said. It should be autonomous, and it should be autonomous and voluntary from the side of the donor, and also from the side of the patient. But our information is on all renal replacement therapies, so that people know the benefits and the advantages and disadvantages of dialysis, of transplantation with a deceased donor, and also with a living donor. So it's I think it's a balanced presentation of all your options at a point in time when your options are still open to you, so that, for example, preemptive transplantation is more is in any case an option at that time, because we know of the benefits of that on the long term.
And I think one of the aims is also to increase the understanding within the surroundings of the patient, what it means to be a kidney patient, yeah. And to maybe to open a sphere that something can be discussed in the social context of the patient, and it may also open the way then for people to think about potential be a living donor. So is that right?
Yeah, on the side of the network, it can generate some champions for the patient, some advocates, and on the side of the patient, it can remove this pressure, this awkwardness that they may feel in initiating a conversation about these topics. You know, illness is in many communities a difficult topic to talk about, can be a taboo so it can remove this pressure, because the professional comes to your house and talks about it for you, and it can kickstart that discussion, which can be difficult to initiate. Yeah. Luuk knows because you've also participated in this project.
Yeah. Okay, Marta's maybe, do you hear us, Marta? Okay, Christophe, what was your opinion about the presentation of Geir?
Okay, well, so if we want to focus on how to optimize the pool donor, so I have a burning question to Geir. So Geir, there is one topic that is not directly addressed in the survey you conducted, which is, or whether a very important topic in the process of kidney donor evaluation, which is the way we are determining the pre-donation GFR and which value we considered as acceptable. So my first question is why there is no this point in your survey? Do you think that there will be a place for a survey around this notion, which is how to evaluate the pre-donation GFR? And more generally, what are your thoughts about on this question? Thank you.
Thank you, Christophe. I'm very glad to be asked that question, since you are also an expert on this. it is, I think it's a significant barrier to donation. Many donors who are highly motivated, well educated on the risks of donation may not be allowed to donate because they are they do not have a good enough renal function. And in our clinical experience, at least in my center, we see some donors that are declined due to not having a good enough GFR. So traditionally, the GFR acceptance criteria has been for many decades has been one limit that has been universal for all donors, regardless of gender or age. And now there are differing views on this, and I believe that many centers are now choosing to go to GFR limits that are more adjusted by age, or that are depending on the age of the donor, since you have the physiological decline in GFR by age, so that a limit of 90 would, a flat limit of 90 in GFR would perhaps discriminate some older potential donors. So I see this, this is a point, if we are trying to make a criteria universal and more defendable, then we should also try to look at this and try to, of course, if it would be possible to develop a survey and to find out what is the status, for example, in Europe right now. I suspect that we would find many different opinions and many different ways of doing this. And I think it would be a strength that there would be more equality among the European countries and the different centers. And I think that it would be very good to have a light on this subject, since it is a very important reason for declining or excluding potential donors. Yes, in Norway, we have, for the last years, we have in our protocol now, we have a variation in the GFR limit depending on the age of the donor. This is the same as in the British Transplantation Society guidelines, and we are inspired by those. But I'm sure that there are many different ways of seeing at this.
Thank you, Geir. Well, I've also a question for you that more or less relates to this question. We concluded that sometimes a potential donor is denied access to donation because we have a misinterpretation of the kidney function. You told about the quality of the information that we are giving to living donors, to potential living donors. What is your feeling if we improve our way or contents of the information that we give? Will it in fact decrease the number of living donors or increase the number of living donors if we are able to give them the right information?
I'm not sure about the effect on the end result, if there will be a actual increase or decrease, but I think that if you put more resources into a field, no matter what you do, then you will improve that field. So just the fact that we are discussing this now, putting light on this, then we are improving this field. And when there are surveys or research being done, discussions in hospitals, that's advancing the field. And I think we should try to advance this field as much as possible. And I think that it would be a strength, and it would be more defendable for the field of living donation if we could have structured information, and if we could have as much as is logically possible that we have some good structure information that is in writing, and also if we would have some good ways to test the information, then I'm not sure if we would end up with fewer donors or more donors, but I'm sure that we would be advancing the field of living donation, and it would also mean a lot for the how we look at informed consent and what we consider to be informed consent. It is very important that we try to be as structured as possible to defend this practice that we are having now. So yeah, to your question, it's I don't know, but
I'm saying the most important thing is that donors are better informed so that they are satisfied about the choice they made.
Yeah, and I also think that it's better for us, then it's easier for us when we are giving information, than if we have some ways of doing it that we know that others have tested before us, then it's also maybe easier for us, maybe it's even simpler for us to do this job. When all this new research started coming out for the last decade, then people suddenly had a much more difficult job of how to talk to donors about risk. Yeah. But if there would be available more structured information or written tools that would help us to convey this information, maybe then it would be easier to inform donors. Maybe that also is a barrier to living donation, how the transplant professional perceives the difficulties of potentially informing a donor. Yeah. So it could be many ways of looking at it, I think.
Yeah, thank you. Again, I invite the attendees and the audience to post questions in the Q&A section if they would like. Marta, are you able to give some comments on the presentations that we heard, or is the connection not well enough?
I hope so. I'm having some difficulties with my internet. So I want to congratulate both speakers, because the topics are not common, are not the typical topics that we listen to when we speak about living donation. But I think they are the most important ones, because unless we approach potential donors and recipients, we won't have any living donor transplantation. So I think it's of utmost important to speak about this. I wanted to address a question or a comment to Emma. I had heard about your home-based method of approaching potential donors, and I was thinking it was home, really home. When I saw your pictures of areas, so it's more a group. A group that you are teaching, or that you are
I'm afraid that we cannot hear Marta at this point.
I think the question is about
your sharing information.
Please, Emma, go ahead.
I'm not sure, but I think the question was about whether it's home-based or just outside the hospital-based, and I think that's a good point. In general, it's a home-based approach, and in general it is in the home, but sometimes either the home is not appropriate, it's maybe too small, or there are other factors involved, maybe animals, pets, or other things that make a barrier to having it at the home. But we're very flexible. It's a whatever it takes approach. So and sometimes the group that's invited is just too big for the home. So we've had sessions with 30 attendees, and sometimes it's even more. So then we help the patient find an alternative location, which has been, for example, a church or a school, or some kind of community-based area. And I think the most important part is that it's near the patient, in their own community, rather than the hospital, which can often be a very an emotional place or a scary place sometimes for some people. So you're maintaining this outreaching element by going to the patient in their own community, and I think that's the most important thing, and having this large reach into that community. I hope that answers your question.
I think Marta's not able now to answer your remark, but thank you, Emma. Well, another point, Emma, that we might discuss is
family base unless the group is too big. Now I understand.
Yeah.
Emma, another question that we might be interested in is how do you organize this home-based education? Do you does each hospital have to educate own people to do this work, or do you propose that there is a regional team or a national team? What is your vision about that?
Yeah, I think it's a good question that you indicate that we're now sort of in this new phase in the Netherlands of trying to go from more project-based, which was more grant-based approach to a structural approach. So it is important that the educators go in couples, in two educators for safety, but all kinds of other procedural reasons. So that's important to maintain that they're well trained. And I think a regional approach is a good approach because you can collaborate with the referring hospitals, so with the academic hospital or the transplant center, and those centers around it that feed into it, so that you can make sure that there's continuity of care, but also agreement with the information that's being given. I think that's what you're alluding to there, Luuk. But perhaps you want to share also some of your own experience.
Well, I fully agree. I think that it needs some experience to be successful in this type of education. So I think it's more worthwhile to organize it in a regional way with teams that have a lot of experience in the end. Yeah.
And I think it's a better base because it's more flexible, but it's more solid. So if one person is ill or goes on maternity leave or for any other reason isn't available, you have a solid base of those people who can offer this without gaps. So I think that's a better approach than just having one person who does it, and that's quite a fragile structure then.
Yeah. Well, I would like to proceed now with the question from the audience, and that's about measurement of GFR. We already talked about the criteria for donation, which limit do we use for GFR, and the question is about if eGFR is perfectly normal, but GFR is low, how to proceed? Do we need repeat measurements, or do we have to measure GFR in another way? Christophe, maybe you can comment on that.
Yes, thank you, Luuk. Thank you for this interesting question. Well, first of all, I think we have to make clear that evaluating GFR in the context of a living donation should be quite easy, and it shouldn't be a big deal to guarantee that we have a trustable and reliable reference method to directly measure GFR. We are talking about individuals who are very homogeneous in terms of renal function. They all have normal or near normal renal function, and usually they are quite healthy. So then the other potential issue is regarding the analytical part of the reference method we are using, and basically today there are reference method using a very robust analytical measurements, and I'm thinking, for example, to the Yohexol currents. But anyway, I acknowledge that we can be from time to time in a situation when there is a significant discrepancy given by the estimating equation and the so-called reference method. In this specific case, I think what can be done is to address first the result of the estimating equation, for instance, by turning to cystatin C based equations, which, and in this case, if the result given by the cystatin C estimating GFR with the creatinine GFR, then we can suspect that we are in a situation where the creatinine is not a good GFR marker in this specific individual. In the case where cystatin C and creatinine basically gave the same result, so we have to question the result of the measured GFR, and in this case, I think yes, it's worth repeating the GFR measurements.
Yeah, and would you then use the same method or use another method?
Well, there are not many centers that can afford different and several reference methods. So if you are in a center where different measurement methods are available, yes, it may be useful and pertinent to change the reference method.
Yeah. Okay, coming back to the topic of Geir and giving information to donors, that's part one of the story, but testing whether they have understood the information, Geir. Are you considering a guideline maybe on how to test the knowledge of donors especially on the risks of donation?
Thank you. That's I can say that I've thought a lot about it, and it is not a simple matter. Maybe there would be many different ways to test it according to the situation and according to the donor and the transplant professional. Maybe there is one universal way that we should choose. I have seen some examples of how it can be done. I know that I think it's University of California, San Diego, and Robert Steiner has some questions that they ask donors, some simple questions that they ask donors just to test that they have understood basic facts surrounding renal transplantation and the process and things like that, but not specifically maybe into all the long-term risks. I would hope for maybe the first step in this direction to be something like having a maybe just agreement on which risks to disclose and how, and then trying to maybe have some place on the internet or a place that would be accessible where it is possible to read about this. I think there is some I think there would be some ways maybe to improve the information given, because these are quite complicated pieces of information to give to potential donors, and so it has to be sometimes maybe simplified. The language should be proper to the situation. So I think the largest potential right now, I think, would be just to try to improve the written information given as much as possible. I would hope that would be a place where we could maybe make an effort in the future. And then the next step, of course, it is very good to have some way of testing it, but I don't have a clear idea of what would be the best way. Maybe there would be maybe in the future, maybe we could try to test different ways of testing knowledge, so that we would do something that is knowledge based. But right now, I don't have a simple answer to that. No.
Emma, would you like to comment on this?
I just wanted to comment to say I think it's important at the end of the process that the donor understands all the risks. But if somebody who's wearing a white coat says, do you understand the risks? It's a very closed question, yes or no. And it's quite difficult for somebody to maybe admit that they don't quite understand the risks, even though someone's just told them what all the risks are. So I think it's important to incorporate open questions. I often ask donors, do you have any concerns, knowing what you know now about donation? So something a little bit more open, and it's important to incorporate these more open questions multiple times during the process, and perhaps then a more concrete knowledge test may be appropriate at the end of the basic things that you want to know. But it's a process, I think.
Yeah. So we are close to the end of the session, but maybe Marta, do you have a final question for one of the speakers or the other panelists?
Yeah, sorry, I'm not having my best afternoon on the internet. I had several questions for Emma, and some of them probably you answered before, but I'd like to underline or to discuss maybe with you. You had a slide underlining some absolute barriers that I would say are not absolute barriers, like old age. I don't know what's the limit. It depends on the person, no? Or the ethnic group. You were suggesting that those were non-modifiable factors affecting the potential of donation. And I think we don't have absolute barriers, really.
No, I think just perhaps a little bit question of interpretation. What I meant to say is that research has shown that those kind of patients with those characteristics are less likely to have a living donor. It's not an absolute barrier, and it's not an absolute contraindication, of course not, no. But it makes it less likely to happen. So those are non-modifiable in the sense of you can't change your age, but it's something to be aware of in the process.
Because I think that we are really changing the paradigm in this subject, because all donors have less time on risk. So we are getting more and more older couples, and they understand that they want to live their end of their lives together with a better quality of life. So it's changing. It's changing from the father to the children to other stages in life, and I think that's important. And also for the ethnic groups, we have many immigrants, and you may have a prejudice thinking that because of religion or other reasons they wouldn't do it, and sometimes they have really clear ideas about the family group and what it means to have someone on dialysis versus having someone who feels better and can work and other aspects of life. So yeah, just to underline that those are very important groups that can access living donor transplantation.
Yeah, okay, thank you very much. Well, I feel that we can proceed with the discussion for some time, but unfortunately, I have to have a look at the clock, and time is over nearly now. So I would like to end this e-seminar by thanking the presenters for their great contribution, and also the panelists, Christophe and Marta, Geir and Emma, for the presentations. Thank you very much. I have a few closing remarks. The next working group e-seminar is titled The Revised KDIGO Clinical Practice Guideline for Glomerular Diseases. And this is scheduled on May 13, and it is organized by the Immunonephrology Working Group. I already thanked the presenters and the panelists, but of course I would also like to thank you attendees very much for attending this e-seminar. And please stay connected for 1 more minute. You will be directed to a short feedback survey that should take no more than 1 minute of your time to answer. And this will be providing us with very useful information so that with your help we can improve the quality of our next seminars. So thank you again all, stay healthy and have a pleasant evening. Bye-bye.